Welcome to Roadmap to Residency. In this video, we are going to walk through high-yield diabetes mellitus management questions that you are likely to see on your Step 2 board exam. This is not a lecture on diabetes. Instead, we are going to focus on how to approach question stems and use test-taking strategies to get the right answer, even when you feel unsure. If you have not already reviewed the fundamentals of diabetes, make sure to go through the endocrinology sections of your preferred question bank and board review resources before watching this video. That way, you can use this walkthrough to sharpen your skills and reinforce what you already know. Make sure to like and subscribe so you do not miss our other board review content. And if you want one-on-one tutoring or residency application guidance, visit us at roadmaptoresidency.com. Let us get started. Here are our learning objectives for today. By the end of this video, you should be able to apply a systematic approach to diabetes management questions on your board exam. You will learn to recognize the classic clinical vignettes that come up over and over again for type 1 and type 2 diabetes. We will work on identifying the key buzzword findings that point you toward the right medication choice. And finally, you will practice choosing the correct management for emergencies like diabetic ketoacidosis and hyperosmolar hyperglycemic state, as well as chronic complications. Remember, these objectives map directly to what you will see in your question banks. After this video, go back through your endocrinology questions and you will notice these patterns immediately. The very first thing you should do when you see a diabetes question on your board exam is ask yourself two questions. First, is this type 1 or type 2? And second, is this an acute emergency or a chronic complication? For type 1 versus type 2, look for the classic demographic clues. Type 1 patients are typically young, thin, and present with diabetic ketoacidosis. They have absolute insulin deficiency. Type 2 patients are usually older, overweight, with a strong family history. They have insulin resistance. One tricky scenario the board loves is latent autoimmune diabetes in adults, which looks like type 2 initially, but the patient stops responding to oral medications and needs insulin. For acute versus chronic, if the question describes altered mental status, small breathing, fruity breath odor, or severely elevated glucose, think emergency. If the question asks about screening intervals, medication adjustments, or new-onset proteinuria, think chronic complication management. This framework will instantly narrow your answer choices. Review the endocrinology pathophysiology chapters in your board review resources for the underlying mechanisms. Let us talk about buzzwords. On the board exam, certain keyword combinations should immediately trigger a specific diagnosis or management decision. When you see small breathing, fruity breath odor, anion gap metabolic acidosis, and a young type 1 patient, that is diabetic ketoacidosis until proven otherwise. When you see extreme hyperglycemia, often over 800 milligrams per deciliter, with altered mental status and severe dehydration in an elderly type 2 patient, and notably no significant ketosis, that is hyperosmolar hyperglycemic state. And here is a classic pharmacology buzzword association. When the question mentions renal impairment, with an estimated glomerular filtration rate below 30, or a patient about to receive intravenous contrast dye, they are testing you on metformin contraindications. The board loves asking about lactic acidosis risk with metformin. Write these buzzword associations down and drill them with flashcards. They come directly from the clinical vignettes you will see in your question banks. Here is our first case. Read this question carefully. A 52-year-old obese woman with type 2 diabetes on maximum dose metformin, and her A1C is still above 8%. She also has heart failure with reduced ejection fraction. Before you even look at the answer choices, what should you be thinking? The question is asking you to pick a second-line agent, but here is the test-taking strategy. The heart failure history is not just background information. It is the key to the question. On board exams, when they give you a specific comorbidity, it is almost always relevant to the answer. So before we go through the choices, ask yourself which diabetes medication has a proven mortality benefit in heart failure. Hold that thought as we walk through the answer choices on the next slide. Let us walk through this step by step. First, analyze the clues. She is on maximum metformin and still above target. That means we need a second agent. But the real clue is the heart failure with reduced ejection fraction. On the board exam, whenever they give you a comorbidity, it is driving the answer. Now let us eliminate. Choice A, sulfonylurea, causes weight gain and hypoglycemia but offers no cardiac benefit. It is not wrong per se. but it is not the best answer when heart failure is present. Choice B, thiazolidinedione. You should eliminate this immediately. Thiazolidinediones are contraindicated in heart failure because they cause fluid retention. This is a classic board trap. If you see heart failure plus thiazolidinedione in any answer choice, cross it out. Choice D, a DPP-4 inhibitor, is a reasonable diabetes drug, but it is cardiovascular neutral, meaning it does not help or hurt heart failure specifically. Choice E, insulin, treats the glucose but does not address the heart failure. The correct answer is C, an SGLT2 inhibitor. Drugs like empagliflozin and dapagliflozin have landmark trial data showing reduced cardiovascular death and heart failure hospitalizations. This drug class is a board favorite. Make sure you review the major cardiovascular outcome trials in your endocrinology and cardiology resources. Here is case 2, and this is a classic board question. A young type 1 diabetic who ran out of insulin now presenting with the textbook Diabetic Ketoacidosis picture. Nausea, vomiting, abdominal pain, and small respirations, which is that rapid, deep breathing pattern. Her labs confirm it with a glucose of 450, a pH of 7.15 showing severe acidosis, a bicarbonate of 8, and positive ketones. Now here is where most students make a critical mistake. They see diabetic ketoacidosis and immediately jump to insulin. But the board is specifically testing whether you know the correct order of management. Look at her blood pressure, 90/60. She is hypotensive. She is severely dehydrated. What happens if you give insulin to a profoundly dehydrated patient? You can cause cardiovascular collapse and dangerous shifts in potassium. Think about the sequence of management before looking at the walkthrough. Let us break this down. The diagnosis is straightforward. This is diabetic ketoacidosis. But the question is specifically asking about the most important initial step. This is a management priority question, and the board loves these. Here is the critical teaching point. In diabetic ketoacidosis, fluids come first, not insulin. The patient is profoundly dehydrated, often with a fluid deficit of 5 to 10 liters. You give 1 to 2 liters of normal saline in the first hour. Why not insulin first? Because insulin drives potassium into cells. If you give insulin before checking and repleting potassium, you risk life-threatening hypokalemia and cardiac arrhythmias. Also, if the patient is severely hypotensive, insulin can worsen hemodynamic instability, so the protocol is fluids first, then check potassium. If potassium is below 5.3, replete it. Then and only then do you start the insulin drip. Choice D, bicarbonate, is a trap. Bicarbonate is only indicated when the pH drops below 6.9, which is rarely tested but important to know. The take-home message for any diabetic ketoacidosis question is to always think fluids, potassium, then insulin, in that order. Review the diabetic ketoacidosis management algorithms in your critical care and endocrinology sections. This is one of the most commonly tested comparisons on the board exam. You need to be able to distinguish diabetic ketoacidosis from hyperosmolar hyperglycemic state. Here is how to approach it on test day. If the question gives you a young type 1 patient with an anion gap acidosis, positive ketones, and a pH below 7.3, that is diabetic ketoacidosis. The glucose is usually in the 300 to 800 range. If the question gives you an elderly type 2 patient with extreme hyperglycemia, often over 600 and sometimes over 1000, altered mental status, and notably no significant ketosis, that is hyperosmolar hyperglycemic state. The pH is usually above 7.3. The hallmark is a markedly elevated serum osmolality above 320. Here is the critical board pearl. The question stem will often include both glucose and pH. If the pH is low and ketones are present, it is diabetic ketoacidosis. If the glucose is extremely high but the pH is relatively preserved, it is hyperosmolar hyperglycemic state. Both conditions require aggressive intravenous fluids as the first priority. But hyperosmolar hyperglycemic state actually has a higher mortality rate, which is a frequently tested fact. Review the emergency medicine and endocrinology chapters in your board review materials for detailed management algorithms. That wraps up our diabetes mellitus management walkthrough for Step 2. Let us quickly recap what you should take away from this video. First, always determine if the question is asking about type 1 or type 2 diabetes, and whether it is an acute emergency or a chronic complication. Second, for medication selection, match the comorbidity to the drug class. Heart failure means SGLT2 inhibitor. Atherosclerotic cardiovascular disease means GLP-1 receptor agonist. Proteinuria means ACE inhibitor or ARB. Third, for diabetic ketoacidosis, remember the management order. Fluids first, then potassium, then insulin. Fourth, for insulin adjustment questions, match the timing of the abnormal glucose to the type of insulin that covers that period. Now here is your homework. Go into your question bank and filter for diabetes and endocrinology questions. As you work through them, apply the frameworks we discussed today. You will be amazed at how many questions follow these exact patterns. If you found this video helpful, please hit that like button and subscribe to our channel. Share it with your study partners. And if you want personalized tutoring or residency application guidance, check out our expert tutors and residency advisors at roadmaptoresidency.com. We are here to help you succeed. Good luck with your studies, and we will see you in the next video.